Hello, my name is Janice Hansen, and I'm an oncology social worker. Today I'd like to talk to you about managing difficult patient encounters. And I think that this is a wonderful opportunity for you to begin to think about this process in a very different way than you might be used to thinking about it or responding to these particular patients. As you know, it's much easier to deal with people we perceive to be good patients who only have a medical problem, not a psychosocial problem, where the diagnosis is clear and there is available effective treatment. However, for safety net healthcare providers, there is no escape from difficult patients. Today, we're going to look at what is important to know about this type of interaction and how to manage them more effectively. The goals of this webinar are to identify two different types of patients, including family and caregivers, we often consider difficult. Examine behavioral interventions that improve interactions with challenging patients. Review communication strategies and attitudes of healthcare providers that affect encounters with patients. And improve effectiveness in diffusing difficult patient-family encounters. And that will help you reduce the emotional exhaustion and perceived stress related to these encounters. That will help you. By participating in this webinar, you actually have the opportunity to circumvent stress by developing the ability to act more effectively in any given circumstance. And as a result, we hope you will feel less burdened by your patients and no longer secretly glad when they don't show up for an appointment. In general, the more skilled and competent we feel, we experience less stress. So in a way, learning these skills is actually a form of stress management, and we can all use more of that. Here are some important considerations to keep in mind as we start this webinar. First of all, patients and families experiencing a health crisis are already in a state of distress. And that automatically includes having behaviors that may not be normally what they would engage in. So you are dealing with patients who are facing their worst fears. And if you're a fairly new healthcare worker, you might be too. These patients and our encounters with them require more time and attention. You just need to be prepared for that. It's sort of the 80-20 rule. 20% of your patients take 80% of your time. And we feel pressured to act quickly versus respond thoughtfully. This webinar will give you an opportunity to create a space where you notice your reaction, but then you can respond thoughtfully. And we know that you'll get to practice this skill quite often because 15 to 18% of clinical encounters are perceived as difficult by healthcare workers. That's 1 in 6 encounters. Just think about your caseload and how many people that might involve. So professional development like this webinar is both a component for your work as well as a buffer against burnout. Here are some other considerations about human relationships. We are all in relationships. Relationships at work, relationships with patients, relationships at home. At work, it's not about the relationship of just doing the work in our relationship to that task. It's about how we do the work in relationship to the patients and the people that we encounter. So it involves how we feel about doing our work as well as who we are working with. We get to make thoughtful choices about how we respond versus how we react. Rather than continually asking, what's wrong with this person and how can I get away from them as quickly as possible? We're going to encourage you to consider asking, what can I do to help them and effectively address their concerns? And this professional growth involves both skill and character, including our own emotional intelligence, sensitivity, and professional ethics. So part of the skill is the ability to consider the perspective of another person. Part of compassion and character is being willing to do so, rather than simply believing there's something wrong with the person because of the behavior they're displaying. So if you look at this particular graphic on the right, you'll notice that you can see how it can look different depending on your point of view and your focus. Are there 3 logs or 4? So we're going to be talking about how we manage that perspective and the relationship. Healthcare workers and service providers have the opportunity and responsibility to affect the outcome of these interactions, otherwise known as responsibility. So we all know what it means to have a responsibility for a task, but this particular webinar is really going to focus on how you actually respond to the people that you're working with while you're performing that task or that service function. As you can imagine, labeling the patient as difficult has negative implications and may result in providing suboptimal care. And legitimate concerns can be overlooked or not fully evaluated. Therefore, we're going to shift the way we define the problem, away from what we often refer to as the patient's character to the encounter and how we handle it. This webinar will move from simply identifying the bad behavior, which we can do quite easily, and consider communication skills and personal behavior that affect the outcome. We're going to look at our approach to the person in the difficult encounter. In so doing, we're going to improve our responsibility. In some, it's more productive to regard an encounter as difficult rather than to label the patient or family as difficult or problematic. Labeling them as difficult is an action of our part as a clinician, not the patient, which in turn defines and sets the rules for our encounter with them. So you might have remembered from your sociology classes that how you define the problem is how you also define the solution. As I've said many times, we have a responsibility to manage the interaction as professionals. So let's briefly look at what the common difficult behaviors are that we encounter. We won't spend much time talking about them, but I just want to acknowledge them here in this slide. If we've been in healthcare for any length of time, we can all nod our heads in agreement that these are challenging and occur in each of our practices. We might even be able to recall specific examples right now. Just reading the list can generate a visceral response and uncomfortable memories for some. Add in evidence of substance abuse, mental health instability, and the encounter becomes even more complex. Our temptation is to have as little to do with these people as possible. But please remember that these behaviors are manifested in the context of the interaction between the helper and the person, between the navigator and the patient. And if you're part of that encounter, you have the opportunity to influence them by how you respond. So what have these encounters taught you about your navigator experience and practice so far? And what do you still want to do about them? Or what do you still need to learn from them? Potentially difficult encounters look like this. You can see the list that's been compiled in the literature. But notice how the literature often refers to the patient as the problem in the medical setting, not the clinician's attitudes, behavior, or response to the patient. You'll often hear these patients described as generally unlikable, that they take up a disproportionate use of the healthcare services, they're complainers, and we believe they have more severe symptoms because they do not do their part to take care of themselves, to participate in getting well. Keep this in mind. Patients are deemed difficult based on the degree to which others, usually us in the healthcare world, perceive them as having control over their behavior. So in this model, especially difficult patient encounters occur when we see ineffective illness behavior on the part of the patient, and it interacts with our ineffective professional behavior. In some, not all encounters with the same patient are difficult. You might have some colleagues who can work with a particular client you think is very difficult, and they seem to manage just fine, and vice versa. So how we manage and how we manage our relationships with these patients, how we manage ourselves, makes a difference. Everyone feels distressed when things don't go well. When we don't manage these encounters well, everyone suffers. And there are often more complaints. We complain, they complain. We may not have enough time to build rapport and find that we just want to focus on the medical aspects without attending to the distress in the relationship. We want to believe it's just all about them and not about us. To that end, uncaring encounters with healthcare professionals depersonalize patients and increase their vulnerability. I'm going to say that again. Uncaring encounters with healthcare providers depersonalize patients and increase their vulnerability. When that happens, patients are not respected, they're not listened to, not treated as whole human beings. And eventually, staff just simply become indifferent to them. It's a common tendency to look to our favorite patients for job satisfaction, while giving less attention to those we consider difficult. In addition, patients are worried that they will be considered difficult and then receive poor quality of care. But as you can imagine, encountering and managing patients in this way does not fulfill our reasons for getting into healthcare. We did so because we care, not because we wanted to act like we didn't care anymore. We did so because people matter to us. So discounting them or their behavior doesn't help. And we got into healthcare because we wanted to make a difference. We didn't get into healthcare thinking we're just going to take care of the well and the easy. So this is part of our work. So what is our part? How do we contribute to this interaction, this relationship, in determining whether it's difficult or goes better or goes well? It's important to understand what aspects of our own personality and emotions contribute to the situations. So it's important to take some time to really consider our own personalities, our own tendencies, our own personal histories, what formulated our views on life, our family, our cultural backgrounds, our values and biases, our beliefs and attitudes. Noticing what our emotional hot buttons are that influence our reactions to patients. Also consider our comfort in managing patients with different sexual preferences or religious ideology, or with particular conditions such as morbid obesity or substance abuse. Understanding ourselves helps us to understand why difficult encounters can arise with patients. And it also helps us to know and accept our own limitations, strengths, and weaknesses, and to have an opportunity to work on them or to be able to learn from them. In this approach, we recognize that it's more productive to regard an encounter as difficult rather than label patients as problematic and difficult. You can see the wisdom in this because it then becomes an issue of really addressing the problem rather than considering the patient the problem. So let's look at this list. We talked about our personalities and beliefs a little bit, and how we define the situation based on those beliefs and biases. Our communication skills and professional attitudes really influence how we behave and how we come off in any interaction with a patient. So, do we know how to speak diplomatically? Do we know how to hold our tongue and be patient and not say the first thing that comes to our mind? Do we really have an attitude of respect and collaboration? Also, the timing, where we're encountering patients. Are we rushed? Are we in a private setting? What are the circumstances around this encounter? And then to notice when our perceptions and expectations are different from that of the patient, so that we can put ours on hold and suspend that long enough to really hear their story before we can begin to interject our own advice or considerations. And it's not surprising that knowing that difficult encounters become less stressful when we are adequately rested and happy in our own personal lives. So if we're especially stressed out about something, we're not going to be bringing our best selves to that encounter. And after we develop a better understanding of ourselves, it stands to reason that we can begin to have a better understanding of others. Simply as we become more compassionate with ourselves and our own life challenges and how we sometimes can even be difficult, we can appreciate what might cause another person to behave that way. So this particular quote just reminds us to really take time to get to know people, to walk with them, run with them, share their triumphs and their sorrows. Maybe they don't dance through life as you thought. Don't judge. So here are the two main types of difficult patients. There are those that are just having a very normal stress reaction, and then there are those that have more personality or character disorders. Both can be very demanding, but for different reasons. One is primarily just scared and trying to regain some control in their life. The other likes to be intimidating, really enjoys kind of stirring it up and becoming more a power person in the relationship. So let's look at this list. With a normal stress reaction, people get frustrated. They get irritable. They might not think as clearly or be able to grasp information as easily. I imagine you have had encounters, as have I had, where a person has been given some very difficult news, but they really can't hear it, and they only hear parts of it. For example, someone who's been told that their disease is worse than they thought and that they have to do more treatment and it's going to take more time and investment on their part. And they can't hear that. They just want to believe that everything's going to be just the way it was and they're not going to have much disruption in their life. Also, they're not remembering things. You find yourself having to repeat things over and over. And so it's a sense of they can grasp a little bit of what you're saying, but they can't get it all. It's certainly not all at once. They might be more isolated where they aren't really drawing on the support resources available to them, and as a result of it, may actually become more upset. They start to ruminate and believe more of their own thoughts about things rather than really taking time to check it out with anyone. And they overall just feel overwhelmed and anxious. And so with this particular list, it feels more manageable. It's a little easier to comfort these folks and to find some kind of resolution to reduce their stress and be able to engage with them in a more productive way. I recently learned also that people suffering from post-traumatic stress disorder, or PTSD, are also ones who are not always very compliant. So they don't always keep all their appointments. or follow all of the directives and managing their treatment. I thought this was really interesting. It was provided in a context of working with veterans who have PTSD. And so if you wanted to learn more about this, you might want to consult with your VA health specialist and learn why that occurs. Now, with people with personality disorders, these are folks that feel just generally very different when you encounter them. Their emotions are very unstable, they're much more impulsive, their relationships are chaotic. Sometimes they just even can't hold a job because they tend to flare up and have difficulty just having a reasonable relationship with anyone, often very demanding, and they also make it hard to introduce new ideas because they're so convinced that the way they see the world and the way things are in their mind are true for everyone. They also tend to exploit others for their own gain. So they like to have this sense of this one-upmanship. I referred earlier to sort of that power play that they tend to exhibit. So they really enjoy manipulating others, manipulating the situation, not telling the complete truth, sort of suggesting little bits of information that aren't the whole story to make it appear one way when it's really another. They're actually underneath it all very dependent. They need someone to be part of that interaction. So let's look at how this plays out with certain kinds of personalities. So the sergeant is the one who is having more of a normal stress response. And so they're going to come across as being a lot more demanding. They want more tests. They might threaten lawsuits. They have rigid expectations and need to control the situation because they're feeling so out of control. And it's more of a fear response rather than a manipulation response. They can be guarded and vigilant or overprotective. Again, that sense of regaining some control over a situation that feels out of control. They can be impatient as a result of that. And they are not often able to even acknowledge their own fear or lack of control. So here are some of the comments. You might hear from them. Why are you so slow? Can you do something more to relieve the pain? Is anyone in charge here? So they have a sense of really needing more control in their environment. And once they're given some, usually calm down and are much more easy to work with. On the case of Miss O'Hara, she is going to have one that has more of a personality characteristic and character quality that immediately puts people on the defensive and has a sense of just feeling less responsive to any kind of offers to assist. It's like you can never get it right. They always leave you feeling defensive and incompetent. They can have somewhat of a threatening demeanor. They like the idea of personalizing their attacks or making condescending remarks. They're very, very skilled at splitting staff. You know, you don't do it as well as somebody else. You do it so much better than somebody else. And they are just generally much more manipulative. They like to go between being very demanding of wanting things their way and then being excessively dependent, whereas they want you to think that, boy, you're just the only person in the world that can really take care of them. And it feels just a little too intensive with regard to their gratitude. There's usually some other intention behind it. It's not just about the gratitude. It's about sort of drawing you in and feeling like you have to continue to be there for them. And if you're not, then the attention and the behavior can shift to being very angry and disappointed and frustrated with you. If you hear in their voice how they talk about people, they're generally angry with everybody. So it's not just one particular person, but they will single people out to make sure that somebody takes the blame for their unhappiness. But it's very, very hard to please these folks. They will make comments like, my other doctor was such an idiot, a total loser, you're so much better, you do it better. Oh my dear, you're looking so much better today. So they really like to lay on the compliments to get you to lean in more to what they might want from you. And again, as I said earlier, they really like to personalize and use condescending tones in their language. So what is it that you can do with these two types of people? What we'll offer here are interventions that work for most of your patients most of the time, but not all of your patients all of the time. Let's see how it works. So review the chart for indications of mental health history or other issues that could impact your relationship with the patient. Remember, psychosocial issues are relevant. You want to know about their background, about other issues they've experienced, what they normally have presented as far as a coping style, and any other factors that would influence how they're behaving now, as well as know your own emotional triggers and be able to prepare for them. So if you know something gets under your skin, that you have a way of sort of putting yourself on hold in that emotional response and be able to think about what the professional response would be. Have a plan in mind, but be willing to adjust and adapt to the situation. And of course, set the intention to be patient, compassionate, and helpful. Settle yourself, breathe into your heart using a technique in heart math called freeze frame, in which you activate a positive emotion and ask, what is the best way to handle this situation? And then listen to your own wisdom arise. So this is really important as far as a grounding technique, and I encourage you to do a little bit more research on heart math, freeze frame technique, if you want to practice that further. The second step guides the way you communicate in the encounter. Remember that difficult encounters often reflect poor communication. Your skill and intention is to demonstrate good communication, effective communication, professional communication. As in all encounters, the first approach is to seek and establish rapport, develop respect, and build confidence and trust. That begins with listening. Patients appreciate our interest and concern, not only about addressing the relevant health issues, but also about them as people. Effective communication helps us understand patients as a whole person, so that we can better understand how they feel and why they might behave in certain ways. You can do this by asking open-ended questions and simply listen. You can also use reflective listening, which is where you paraphrase what you heard to let the person know that you are listening and you understand. Reflective listening also allows you to make sure that you really have your perceptions about their problem correct, so you can check them out. Next, you want to clarify boundaries and expectations. You want to help the person understand what you are able to do and what you're not able to do. So after you understand what they need and want and expect from you, you can help them understand what is actually possible. So in some cases, you may need to establish contracts or agreements about what you can do and what they can do. So you may have some patients who are very dependent on you to figure out all of the solutions to their problems. And it will be very important for you to be clear about what you can do and what will be their responsibility and what they're able to do in this situation. This builds confidence and their own capacity to participate in this process. And then you want to identify a common goal for the encounter. What are we going to address or work on together in this visit? Do your best to keep it focused and manageable. People under stress have a tendency to want to tell you everything about what's going on with them. But it will be your job to try to focus on what is really the key issue today that needs to be addressed, that is possible to be addressed, and help them sort that out from all the other things they're telling you. Of course, it's important to involve the patient and the family in setting these goals and prioritizing them. Remember, it's not just your agenda. This is a collaborative process, and you want to be able to include them. The third step involves you as part of a larger team. You don't have to figure this out and manage it all by yourself. So you've done your part to prepare yourself. You've listened to the patient and set some boundaries. And you've identified challenging goals. But still, you have some folks that are very, very difficult to engage in that process. So when you have an especially challenging patient situation and you're seeing certain patterns of these behaviors and you're identifying other potential conflicts that could arise in the future, it's very important for you to begin to then work with your team together to develop and share your understanding of these issues as well as your strategies in managing them. You can meet and review your challenging cases in small groups or as a whole team. For example, at our cancer center, we developed a process by which we have key members of departments meet, hopefully on a weekly basis, to review any encounters that have come up or that we anticipate being problematic in the future with our patients. And we can begin to agree on what the issues are and the strategies to address them, as well as develop any resources that we need to have available, whether it's people resources, referral resources, informational resources that can help with the encounter. This may include reviewing how patients may be splitting team members. If you recall, when we're talking about patients with personality disorders, their tendency, some of them, is to make it appear that one person is doing a much better job than another person. And will try to make it appear that they want you to side with them against another team member or maybe even against another family member. It's going to be very important that you remain supportive of your team as well as neutral and not taking sides. So be very aware of patient or family attempts to split their care providers or other family members. And as you know, as a healthcare provider, when you feel judged or inadequate, it then becomes very difficult to provide optimal care. You tend to provide less care and not do as much for a person as you normally would or could do. So be aware of this if you're noticing this in yourself. So partnering up with a colleague can help you feel more supported so that you're not taking the brunt of a especially difficult patient encounter. And then this can involve where you have one person doing one part of the conversation or care and the other person is more in a supportive role. So you can work together and have it be a more productive encounter overall. So when you're responding to patients who have more of a common stress reaction, so we sometimes call this the sergeant, or someone who feels out of control, and the way they regain control is to really assert themselves in a more aggressive way. So when you think about this, you can understand that why they might be concerned, because it's very stressful dealing with a health situation that is progressing or needs attention and is pulling you away from your other life activities that you enjoy a lot more rather than being at the doctor's office. So you have some compassion about what that's like. And your role is to help ease some of that stress in these encounters. So you take time to listen and understand their concerns. You're establishing a rapport. You're helping establish a plan about what can be done to help them to reduce that stress. Keep in mind that when you're addressing issues around pain, you're dealing not only with physical pain, but emotional pain or psychic pain. And that stress and anxiety do not cause the physical pain, but they can make all kinds of pain worse. So the more depressed or anxious a person is, the more likely they're going to report symptoms of pain. And hopefully, with your encounter, you'll be able to reduce the anxiety that they're feeling by addressing their concerns, and therefore reduce their pain and improve their quality of life. However, if the patient appears to be one that is very angry and is spending more time exploring the past medical experiences, you may take some time just to be able to deal with that emotion with them a little bit more and hear them out. So you want to understand more about what brought them to this situation and not just dismiss the anger. And if in fact there was something that occurred in a past medical experience, you can simply acknowledge that you're sorry that that happened. What can we do from this point forward? How can we keep that from happening again? What can we do that will make it better, so that you're focusing again on the solution? And then also ask, when they are most angry, what are they actually most worried about? We will talk about over the next couple slides as well that people who are angry often are most afraid, and it just comes out as anger. You probably have even noticed that for yourself in your own behavior. I mean, think about if you've had children and, for example, they dart toward the street and you might grab them and really shake them and scold them about not running in the street, and it comes off looking very angry, but what you really are feeling is very scared for them. So notice that this is a very normal response to fear, is to come out as anger and irritability. So in your efforts to help people, you ultimately want to help transform their stress response. And these are some phrases that you can consider using when you encounter someone who's in a great deal of stress and they're behaving badly. It might be as simple as, I see that what I said is upsetting you. How can I help? So this is something you might say to someone when you're doing your best to help them, but it feels like it's just getting worse in the encounter. Take a pause and just ask this question so that you don't keep trying harder to do or say something that is actually upsetting to them. And when you are faced with a myriad of problems, and you know that you only have a limited time with somebody, and you want to get to the heart of what's the most important concern, you could ask this: if I could do one thing for you today that would help you feel better, what would that be? Or that would help address this particular situation. And they usually have something in mind and something that you can do. And they can maybe give you a list of things, and you can help them understand which is more likely, because they might be asking you something that they really need to be asking from another professional, like a physician. And of course, this is always a very powerful question. I use it a lot with people when they're under stress and they're behaving in a way that feels very intense. What are you most worried about right now? And what would be most helpful for you? Other ways of getting at where this stress is coming from or this behavior is coming from is to ask how the illness has affected their family. So these top questions are ones that are all open-ended questions. If you're wondering what they look like, this is what they look like. It's usually the how, what, why, tell me more kinds of leads. The last question is a closed question. Have we covered all the concerns that are important to you today? Is there something else that we should be talking about? A lot of times when I'm having an encounter with a patient and it's the first time and they have lots of things they want to talk about and lots of things I want to know about, I have a wrap-up question that always includes this one. And this question has to do with, did we cover everything that's important to you? Have we covered all the concerns that are important to you today? Is a question that you want to ask before you put your hand on the doorknob to walk out the door. Because I will promise you that if you don't, when you put your hand on that door handle, they're going to think of one more thing that has been ruminating in their mind that they want to ask you about. So ask it right up front when you have time, and then just listen. Just listen. So what we talked a little bit about, these sort of angry, anxious responses can come from people who are afraid and grieving, and it can come out sideways. It's also a common response to a new and potentially serious health concern. Of course they're afraid. There are a lot of unknowns and they feel threatened physically, mentally, emotionally, spiritually. The anger may be related to a past experience, though, and so you want to be able to still allow that. We talked about that a little bit before, is the opportunity for them to talk about it a little bit more. If we don't deal adequately with anger and anxiety, the difficult behavior will persist. And so we really need to take time to get at the root of what that is. In addition, many chronic diseases cause great suffering and uncertainty. So it's just part of the process that things can sort of be bubbling underneath the surface, and then they just emerge in a burst of emotion. And this often happens when people have a break between the task of all the treatment or tests and then a time to think about what it means for them. The emotions then now have more room to sort of be expressed and addressed. You can use your reflective listening skills to show that you understand and be just present with them. It may not require a solution at all. It may be just an opportunity to listen and understand. Now, when you're dealing with people who are more manipulative in intent, again, you want to prepare yourself in a little different way. It's very important that you resist the tendency to engage in conflict and argue with this type of patient, because they are really going to know how to push your buttons and hook you in that kind of encounter. So you really want to be prepared that that's possible and know how you're going to respond to that. So you keep a plan and a strategy in mind. You need to be flexible because you may find that in that particular encounter, they are very pleasant and easy to work with. Whereas in the one before that, they were not. And in the one following it, they may not. So allow yourself to be prepared, but also adjust to what's actually happening. Of course, be pleasant and attentive, but you're likely to be a little more pragmatic and focused on the primary presenting issue, because these folks tend to bring in the kitchen sink about everything that's wrong. Remember, they tend to be angry and upset and disappointed by everyone and everything. So your goal will really be to work at narrowing it down to what is the most important issue today that we can work on. And you'll be especially attentive to their nonverbal cues and knowing whether or not they're engaging with you and able to respond to your assistance. So how is their body language looking? Is it tense or closed? What are their facial expressions like? And if they're already agitated or becoming agitated, what were some of the triggers around that so you can address them? If you're feeling like the negative emotions are taking over, either for you or for the person you're working with, take a break and step away. More of the intervention may not be what's needed right now. More of your time and attention. It may be that both of you take a little bit of a time out where you can acknowledge that this seems to be more upsetting. Let's just take a break and take a deep breath and see if we can come back to this in a couple minutes. And whether it's actually staying with the person or stepping out of the room saying, I need to take this call, or I need to do this one thing, and I'll come back and I promise we'll get back to your concerns. So everybody has sort of a cooling off period. Your preparation for dealing with this type of person may also require help from a mental health professional. I say may, but actually it probably would be highly advised if you have anyone on your team that can offer that expertise, because you, again, will need some guidance about what you can do what you should say and when and how you should manage it so that everyone is responding to this person in a similar way. And certainly consult with your colleagues who have more experience, maybe either with this patient or with this type of patient, and they may have a great deal of wisdom to share as well. So, as with all processes, there is an ongoing evaluation. It's important to evaluate what worked, what didn't work, as well as be willing to adapt your strategy. Remember that the definition of a mistake is successfully discovering what does not work. So don't beat yourself up by continuing to try the same intervention in the same way, have the same kind of conversation with a patient and expect it to be different. Someone needs to make a change in how that encounter evolves, and you are in the position to determine what that change will be. So as you look at this list, you want to pay attention to what was the quality of the encounter, how did it actually work out, and again, what worked, what didn't work. Review it as a team. You could certainly do it individually, but having the wisdom of your team and another set of eyes and ears and hearts looking at this can be very, very helpful. There's no need for guilt or shame, no need to assign blame to someone, your colleague or the system, or shift the burden of failure to the client. Instead, such occurrences are simply an opportunity and a time to make a choice to take action in the service of a larger objective in terms of caring at a higher level, being more effective in terms of helping that person navigate the system. So sometimes the reasons about why the encounter didn't go well will be a mystery, and you'll continue to explore them as you meet with this person in future encounters. But you can always evaluate and try different kinds of strategies after you've had some time to review them. But when the same problem creeps up again and again, and you know what it is, you have a better set of tools to adapt and address them. So that's where your competency comes in, is you learn from each of these encounters and it provides you an opportunity to do it better the next time. Keep in mind that improving our skills is an ongoing part of any profession. And one of them is always going to be dealing with difficult patient encounters. And as you become more effective in doing that, you're going to increase your job satisfaction and reduce your own stress. Remember, we don't have to love or even like our patients in order to be able to help them. What's important is to know how effectively we're doing that. So I hope you will take some time to consider reviewing some of these articles and see if they offer anything of value to you as you continue to grow and understand the situation. And you are also welcome to contact me either through my office or email, and that information will be made available in your enrollment process for this particular webinar. Thank you for your time and attention to this important matter, and I wish you great success in your future encounters with difficult patients or patients you consider to have challenging personalities. Thank you.